Right. So all has been discussed already, making my life easy now. So I designed this presentation for a general surgery audience, which I am assuming the majority of the people here are from a general surgery background. My surgical oncology colleagues will already know all this data, and we have already discussed this at length in the previous session. But I'll run through the seminal trials which established different neoadjuvant treatment protocols for esophageal cancers. The most important questions that we need to answer in this current presentation is, why do we need neoadjuvant therapy in the first place? What was the first seminal trial which came about, which established the role of neoadjuvant and adjuvant therapy in resectable GE junction and gastric cancers? That is the MAGIC trial. Then how the MAGIC trial has now been replaced by the FLOT regimen. And then what is the cross protocol? And is there a best regimen between the FLOT and the cross protocols? So why do we need neoadjuvant therapy? And the answer is because with neoadjuvant treatments, your tumor gets downstaged and it shrinks, and which allows better resectability and a higher likelihood of R0 resection, which we know is very important for long-term survival outcomes. Neoadjuvant treatment also treats subclinical distant disease, which is your micrometastatic disease, and the primary tumor is also obviously treated. And later on, if you are anyhow going to operate later on, and if you are doing radiation to the esophagus, the irradiated part of the esophagus is anyhow removed later on, and thereby you reduce the late side effects of radiation, like strictures and stenosis, which are known to happen a few months to years down the line of treatment. And this is the upcoming role of neoadjuvant therapy, in which now you can assess the response, and you can escalate or de-escalate the treatment depending on the kind of pathological response that you achieve after neoadjuvant treatments, thereby ultimately improving patient outcomes even further. So why the need for neoadjuvant therapy is because I think the MAGIC trial, which came a long time ago in 2006, this is before we began before I began my oncology training. This was a perioperative chemotherapy protocol with ECF regimen. So it was the standard arm was surgery alone, and the experimental arm was 3 cycles ECF pre and post surgery. ECF is now an outdated protocol. It's very cumbersome to deliver. As per this protocol, the patient needs to have a 21-day continuous 5FU administered through a indwelling Hickman line, which is which is an absolute nightmare. Now this trial took 15% of patients of the trial patients were esophageal cancers, but it established that the 5-year survivals could be improved significantly from 23% in the surgery alone arm to 36% in the perioperative treatment arm. So you can see the outcomes with surgery alone, of course, they leave a lot to be desired, and they were improved significantly with the application of perioperative chemotherapy, thereby establishing this as one of the landmark trials in its time. Like I said, ECF is cumbersome logistically, and only 42% patients could complete the entire planned 3 pre and 3 post-operative cycles of ECF. Coming to the next landmark trial, that is the FLOT4 trial. Again, this was a multicentric randomized phase 2, phase 3 trial. What the investigators did here was they replaced cisplatin in the ECF to oxaliplatin, which is less nephrotoxic, less emetogenic, that is less likely to cause nausea, vomiting. And in multiple other trials, it has been shown that oxaliplatin, at least for GI malignancies, is as good as cisplatin. Epirubicin, again, in another randomized trial, did not show any efficacy as a single agent, so it was changed to a newer formulation, a newer chemotherapy drug called docetaxel. And the 21-day 5FU was replaced with a simple 24-hour 5FU infusion. Thereby, this regimen was called as the FLOT regimen. And here again, this trial took 24% type 1 G junction Sievert's esophageal cancers. And again, here also, this FLOT regimen, it outperformed the ECF regimen. The 5-year overall survival thing, because of the formatting, it's getting cut, but it was 45% versus 36%. So again, you have a statistically significant improvement in 5-year survival. Interestingly, the survival with the ECF arm was very similar to the survival which we saw in the MAGIC trial with the 5-year survival of 36%. And now you are achieving roughly 45% 5-year survival with the perioperative FLOT protocol. And as of today, even now, this is the standard of care for these malignancies. The important things to note with FLOT compared to ECF was that the tumor downstaging was better, although overall the pathological CR rates were low, but you had better downstaging, that is YPT1, YPN0 were much more with FLOT, and the R0 resection rates were also significantly better.